In this episode in our knee pain while running series, we're actually going over patellar tendonitis. And today I'm going to show you 9 different ways or 9 different methods that we use for patellar tendonitis treatment. And that's going to include some tissue work as well as some stabilization and some assessment. Okay, now assessing the patellar tendon right here is the thing we're having question on with this part of the series. So if you actually grab onto the kneecap here and taper it all the way down, you're going to get into a softer structure right here. Okay, this is the tendon, which is very short. It only goes about this far. Interestingly though, the kneecap is a sesamoid bone. It's a bone that actually is encapsulated within the tendon, which then merges with the quad tendon, which is on top. So again, our anatomical structures which we're interested in with this one are, we have the quad group on top, we have the kneecap or the patella, we have the patellar tendon which attaches to the shin here, and on the side it's nice to kind of roll down here and eventually you get to an area that has a little line like that. That is the lateral joint line, or sometimes we have the lateral meniscus, or a few different types of injuries which are indicated there. Obviously there's things on the inner part of the knee here, but we'll go over that in new videos.
I like to start with assessing the squat, and the reason is I don't like to start with the squeaky wheel and just starting with the knee and just directing exactly where the patient's telling me. So some of the things I like to check for are, is she squatting to one side? Is she loading one side excessively? We'll see this in the front view. You can also see, are her knees shifting inwards or caving, they say. Does she also squat so her knees are shifting too far in front of her toes, which does happen as well. Also, we need to look at her feet and ankles to make sure they're not turning into pancakes and just going completely to the ground. Each one of these has a different correction, but let's just say in this situation she has a lateral shift, which she's going to show right here. So not only is she shifting, but also she has some knee issues as well. So one easy way to correct this is with the quadruped rocking, which is going to help us pattern it back so she's stacking everything well again. With this quadruped rocking exercise, basically you can see that her knees are well now over her toes. Her heels should be flat on the wall, and she's pushing her hips down between her heels, and her spine should be straight. We're tucking forward in this position mainly so she simulates a squatting pattern. So a lot of times you can correct some of that slop into the knees, the ankles, the hips, and also shifting to the side, which she was doing, by doing a patterning exercise like this in the beginning. Granted, this is not something that you would stay on forever. Eventually you do have to go to a standing squatting pattern, but we need to make sure that the brain is talking to the body so we can actually go into the correct movements. Now I like to test single leg stance, and this is what I would call the clock drill. Also too, there's another one called a Trendelenburg test, which is not a clock variety. So she's hitting the 12, the 9, and the 6. The Trendelenburg were basically just standing and looking to see if they have hip drop. So in this, we're mainly looking at the knee to make sure the knee stays stacked over the foot relatively, seeing if the belt line drops, so we're looking for hip drop. And also too, in this video, you can't see much, but we're looking at their upper body to see if they're losing control, they're losing their spinal position or their posture. The reason why this is important is because with the knee, again, with running, we do have stacking that we're looking for, and you're on the single leg a lot. So I'm going to ask her in a second here to do some poor movements, but really what this means is there's no doubt in my mind that this person would have a knee injury if they are losing their stacking ability, such as that one. In this one, we're seeing that she's bringing the chest forward a bit, and this one we have hip drop on. So there's no doubt in my mind that someone like this would have the possibility of a knee condition. Even looking at how she's doing it, she's just shredding the knee up, and there's lots of rotational forces going on. So this is a trunk correction. Now with hip range of motion, we have to consider, does she have proper flexibility within the hip, or is it obstructed by bony issues, osteoarthritis, labral tears, things that basically will not give her free motion? This is passive testing, so basically I'm doing it for her to see if it's actually open. In a second here, so we're going to compare my ability to move her hip versus her ability to move her hip. And really what it comes down to is it's important for her to be able to move her hips well. So we'll do the same style test, but now seated. I'm looking that she can move roughly to the same degrees in and out with both legs equally without lifting the thigh up off the bench. So you see she's doing pretty well on both of these here. They're roughly about the same, which is all I'm looking for. If one's grossly different, then we need to consider the possibility of not that the hip has any flexibility issues or mobility issues, but the fact that she can't control it when she's doing it on her own, which could be a core or a local stabilization issue. You see here, she's basically lifting the thigh up off the bench to accomplish motion. Now, if you're wondering how we would correct if she failed flexibility or motion in both tests here, active and passive, then we would probably work on some hip mobilization, such as we're going to show in the next segment.
This is a really good way to mobilize getting more external rotation, internal rotation, and also axial compression, which we're trying to get the backside of the joint capsule. So the joint capsule is actually made of ligamentous structures, and actually she's got some good flexibility here, but in regards to showing you how to treat it, I will go over it anyways. So usually what I'll do is we'll check external rotation, we'll check internal. We'll actually go into a Schouer's test, which is almost bringing the knee up and across, looking for any pinching, any restriction that she might have, and also coming even a little bit wider and pressing in this direction, so going down the thigh. So usually when we find something, a lot of people actually don't have a proper amount of internal rotation, and they really hang up here. You can actually see their pelvis start to raise, and they'll kind of shift their back around. So what I like to do is I internally rotate and I drive down. So we're actually pressing down the femur or the thigh and adding a little bit of oscillating internal rotation. Same thing with external rotation here. Axial compression and adding external rotation again. And also too, I think it's important to get them into a little bit of circumduction here, and you can also add the same thing. So find out where your restriction is. Here, drive in, and then internal rotation. Now, with the hip as well, we can also mobilize it in extension too. So we've already done that in circumduction as well as flexion. So now we're going to take this here. We have to butt up against something firm here. So this is going to be the pelvis, and we're going to bring her into extension here. Okay? We're not really trying to stretch the hip flexor or anything. We're just trying to get a little bit of end feel at the end part of that joint to make sure there's no tightness of the front side of the capsule. Again, we can do this with external rotation or also internal rotation based upon what she can tolerate. Okay? So if we're trying to get more internal rotation, which is going to be this way towards me, I'm going to pull this way, press in, and then use my body to kind of lean her away or lean her foot away. Obviously, it's nice to really cradle the knee to make sure you're not tearing up any of the meniscus or components right here, because people don't like their knee twisted. So this is just one way to mobilize the hip into extension. Now, mobilization of the kneecap is really easy to do as long as you don't press downward. And this is helpful in cases of the patellar tendon or patellar tendon injury, as well as chondromalacia patella or runner's knee, which can happen underneath. And basically what we do is we make sure that their quad is not contracted, because if it is, show me a quad contraction, we can't move this thing whatsoever. Okay, relax. So all of a sudden she relaxed and this thing slid over. Okay, so what we're looking for here is we're going to take it downward, upward, side to side, and we're going to cup it like this. Take the heel of the hand, you're going to cup the top and the bottom part, and we're going to go up and down, and we're looking to see if there's any restrictions in movement whatsoever. Okay, I'll move my hand a little bit just so you can see, but for the most part you want a nice firm contact on it. Okay, and this is just below the kneecap right here, this finger or these fingers. Okay, so if we find restrictions into this range, we're basically going to push, sliding it this way, not down. Okay, it really is helpful to have the arm providing a line of drive so you don't make that mistake, because it's going to irritate you a little bit. So we're going to spend about 30 seconds, 20-30 seconds oscillating against that restriction, whatever you find. Okay, in this case I'm going downward, but you might find it upward. Okay, 20 to 30 seconds, or if you want to cover all bases, you go both directions. Okay, next, if we're actually trying to go this way, so we take this butt of the hand, or you can actually go like this as well, And you have to make sure you have a contact against the rest of the knee so you have something to press against. Okay? So taking this section and you're going to drive across, and I'll try to do it so you can see in the camera. So again, looking for that restriction. And a lot of times in cases where the knee's been a little bit irritated, or there's been like adhesions or restrictions which form around the kneecap, this is really helpful for getting that movement back of the cap. Because it can be really painful when it doesn't want to move. Next, we're going to push inward, or this is a medial drive. Again, I'm going to hold the knee, especially the joint line section, really firmly because I want something to drive against. In this one, I'm going to show you first with the couple fingers just to show you that I'm driving this direction, but really I want to use the cup of the hand and press across. And notice that my forearm is driving the direction I want to go, making sure not to compress downward, which you'll do if you do it this way. So again, spend about 20-30 seconds. Look for any restrictions that you might find and just kind of oscillate into those really nicely, and eventually this thing will free up real nice. Now in the patellar tendon here, a lot of times we want to treat up and above it first, so we're going to start in the quad group again. So we're going to hold that section right there. We're going to make it so we can pull the leg back. So if you put too much tension right here, you won't be able to pull the leg back. So just make it so we're letting the muscle slide underneath this broad webbed contact. Okay? And we can move this all the way up into the upper thigh.
Now I just showed more of a getting the tissues to move past each other style of tissue work. This style I'm doing here, which we apply a lot of lotion to, we're mainly trying to address that one muscle on its own. In this case, we're working on the quad. So this, we're taking long strokes with lots of pressure, and it's pretty simple to do, and it's tender on a lot of people. The goal of this type is to feel for restrictions and try to break up any gristly tissue within the quad. Now onto the patellar tendon, we're going to use a little bit of lotion here, and we're going to find the patellar tendon and work mainly around it and through it. And she has to have her quad relaxed in this type of tissue work. And again, we're feeling for restrictions. We're feeling of like gumminess or relative firmness to areas around it. And I put her in a position like this so she can't really contract against it. If someone really does have patellar tendonitis, this is going to be a little bit painful. And you're going to have to just do enough to make tolerance, to be able to, so they can tolerate it during that segment of time. I might only do it for a couple minutes. If I can get up to 5, I'm extremely happy. But it is a really tough structure. If you notice that the tendon itself is more dense and rayally than the quad group is, if you felt that in the last section. So overall, it is a more dense structure just because what it is, but you have to feel the relative surroundings. If it's more dense on one side versus another, or it feels like it's not moving, those are the areas that I like to typically focus on. Now, face down mobilization of the SI joint, usually we like to assess. We like to feel whether it's moving on one side versus another side. I like to use the butts of my thumbs there, or like the pads. So now we're going to find those bony areas right there where dimples typically are, and press, and just kind of feel. If we feel that one's not really moving that well, then we're going to enforce a little bit more pressure on that side, such as this. We like to hook it, press in with the thenar eminence, or just around the base of the thumb, and we're going to press down and through the table with an oscillating fashion. Now, it's important not to be on the actual back with this. You're going to find again that the pressure right onto the area of where people have dimples, or what we call the PSIS, is going to be the most important part to push on, because if you're going to make a difference in the SI joint, you have to push there from this angle.
Next, we'll show an adjustment here of the SI joint. Okay, I don't expect any of you to do this on your own. Okay, just roll them like this. We're going to find that same section where they have that dimple and press through. And I don't know if the mic got that. We got the SI joint there on that one, so hopefully it frees up motion of the pelvic ring.
Now, another way to mobilize the hip is through axial distraction of the ball and socket. So I like to assess first, internal, external rotation, and I'm pulling as I actually do that. And again, that is the point of axial distraction. The only way we're going to know if it's different or if it's lacking is if we check with the other side first. So you got to check both. And this is different than the other one that we showed earlier where I'm pressing down through the hip. Okay, again, we're pulling out, feeling for restrictions of internal and external rotation. Another way as well is we can also do an adjustment like a quick yank on it, which is what we call chiropractic manipulative therapy. It's something that I can't suggest anyone do on their own, mainly because they have to be credentialed and trained to do it, but it looks like this. It really does help out with people who have restrictions in their hips, so I wanted to show it today.
Now this is a patellar strap. It'll assist more in cases of jumper's knee, which is just the very bottom part of the patella or kneecap, or the top part of the patellar tendon, or OSGOOD SCHLATTER, which is much lower, which happens in youth athletes, and a lot of times it'll form as like a large bone right here. Usually they have to have an open growth plate to do that. So before I start, this is a very cheap way of dealing with pain, okay? It doesn't fix the problem. It doesn't fix the reason why this knee is happening, which we'll talk about in that rehab section, but I want you to realize that if somebody is determined to do an event, something like this could help. Okay, so what we do is we look for this area that has all the rough spot on it, and obviously this side doesn't. So you put it just below the kneecap, just where it dips down there, and you wrap the smooth side first and the rough side second. And this shouldn't be so snug that it irritates the back side here, because there is nerves, vessels, and much more back here which can be irritated. So keep that in mind. So again, this is used mainly if someone has pain and they are just dead set and determined to do something. A lot of times if squatting and bending and kneeling create pain, we can use something like this to see if it does decrease pain. It'll almost be immediate. So this is something, if you want to try it, I put a link below, but just know it does not fix everything in the long run. Now for those of you who watched all the tips on how to address patellar tendonitis, now we're going to go into the understanding of what patellar tendonitis really is anatomically, how it happens, the mechanics of it, and so on. So if you're not interested in this part, feel free to click away, because there won't be any more tips from this point on. Just know the point of this video is to help you guys understand, not just to give quick tips, so thanks for that. So patellar tendonitis, again, here's the patella or the kneecap, which is a large sesamoid bone, which is encapsulated within the patellar tendon and the quad tendon. The quad, I'll bring this up here. So the quad basically attaches kind of here like this band does. Pain is going to feel like it's right underneath the kneecap, or just inferior to it, just down here. It won't feel necessarily like it's on the bottom as much, but it'll feel like it's down here. It'll feel painful when you stand up. You'll also be scared of stepping down curbs as well. And there'll be pain when you're running, jumping, and deep kneeling. Now the knee, just as in IT band syndrome, in the patellar tendon right here is no different. The knee is kind of stuck in the middle between these other joints. So we have the ankle below, we have the hip above, and we have the core even further up, which a lot of times this whole thing has to be stacked well right here, okay? Consider the patellar tendon here, and say the position right here, I'm going to try to hold it taut, versus here, versus here, versus, let's see if I can do even twisting. All this can affect the patellar tendon in different ways. So really, it's stuck in the middle, and we have to address these other areas and make it so the knee stacks well if we're going to address the patellar tendon for good. Now as we kind of inspect the knee here a little bit, I'll tell you about some poor movement patterns which can be found in running, which can be a major risk factor for developing patellar tendonitis. And the top on my list is overstriding. Next, having excessive hills, poor buildup of mileage or volume, poor squat pattern, muscular imbalances, and as we said before, we have the possibility of that poor core strength, hip strength, or poor control of those, as well as the ankle. Now, rehab of the knee really comes from this region first, then this one, and then finally the knee. And I know this might be far-fetched for a lot of people, because I can't tell you how many people I've had come in that said, well, I don't know why I understand why I'm working this core area in the pelvis, but I got a problem with the knee. When are we going to do something for my knee? And we are, and I'll tell you exactly why here. And this goes for IT band syndrome, patellar tendonitis, meniscal injuries, hamstring injuries, and many more. So when we're looking at the core area right here first, consider how unstable this looks, okay? The only thing holding this and this section of the body together is this part right here. It's the lumbar spine. And if you have a back injury or have had one in the past or have a disc injury, then it's even weaker and these things don't hold together well. So now the other parts which are not included on this, which are, imagine the core on the front side, the back. And then we have the diaphragm which sits inside this cavity which encompasses this entire area. Then we have the pelvic floor as well. All these things keep this thing together. And if you don't understand the reason already, let's just go into exactly how this affects the knee. So say we have, let's just say we have the hip flexor, because we're talking about hip stuff eventually. Hip flexor attaches from here to here and it goes down and attaches right around there. If this is not stable, this will extend and come forward. When it comes forward, it doesn't give this the ability to contract as well as it could to raise this up. Now, if we're talking about, let's just say, the rectus femoris, which is one that goes from the hip to the knee, then let's just say this front side abdominal wall right here, this thing helps pull this thing up, okay? Imagine my thumb here being this area right here where this thing attaches, and imagine me spinning it backwards here. Look at the tension that develops on this band as it spins, okay? And this thing, if you're saying that it doesn't have an effect on the kneecap and the patellar tendon, it's crazy, okay? Now, this also happens on the backside with a hamstring. Imagine me now rotating the other way, okay? This is about to rip my pinky off right here, and this goes on the backside where the hamstrings are, okay? And the same thing happens, the hip has a lot of different movements it can do. It goes forward, backwards, internal, external rotation, side to side, which is abduction, adduction. So when the IT band comes down from this, it's also ridiculous to think that the pelvis doesn't have a strong correlation with the knee right here. So if you're only doing rehab from here to here, you're missing the boat. There's a lot, and there's also down into the ankle. Now, when should you do rehab in this region specifically? It really comes down to what the injury is. If you have a large tear of some type, we have to address the structure which is torn up. That might be a surgical intervention. It might be rehabbing this area, what we call local stabilization, but this is global stabilization. You use the entire body to run and move throughout the day. We need to rehab it together to get this thing to go away. So if you have more questions for me, I do have an entire section on knee rehab on our podcast. It is an entire section only on that. And we do have an industry expert in there as well on knee conditions. So go to p2sportscare.com/podcast and you'll find that. Scroll all the way down. I believe it's in the mid-20s where that one's located at, but it'll greatly help you. So give me a thumbs up if you haven't already and share this with friends and link it to your site. If you have a blog, please share this. Just ask me exactly what you need to share it and I'll help you share it for you. So, Sebastian, over and out.